Thank you for joining us, everyone. Thank you for joining the Center for International Security and Cooperation at Stanford University's weekly research seminar. My name is Harold Trinkunas. I'm the Deputy Director for the Center. It's my real pleasure today to welcome Dr. Adia Benton from Northwestern University, where she's a professor of anthropology and African studies. Professor Benton has long experience working in the field of medical anthropology, among other issues. She's the author of an award-winning book, HIV Exceptionalism, Development Through Disease in Sierra Leone, from the University of Minnesota Press. She's currently working on a book about the West African Ebola outbreak. She earned her PhD from Harvard University. And we're very much looking forward to today on Is Ebola the ISIS of disease? When counterterrorism meets humanitarian medicine. Before turning it over to Professor Benton, just a couple of reminders about the ground rules. Professor Benton will be presenting for about 35 minutes. We'll have an opportunity for Q&A afterwards. Since this is a webinar, please go ahead and enter your questions in the Q&A box down below. I'll come back to moderate the Q&A session once Professor Benton's presentation is done. Professor Benton, over to you. Welcome.
Thank you. Thank you for the warm welcome, Harold, and thank you to you and to Emily and to the audience for, well, Harold and Emily for all of the sort of behind the scenes work, and the audience for paying attention. I'm hoping it's going to be a good conversation. I'm going to try to keep this short, on the shorter side, because I am interested in hearing people's questions, and because this is a work in progress. This is a part of the book that I'm writing about, the 2013 to 2016 West African Ebola outbreak. And I'm hoping to think through this chapter because it's one of the thornier ones. It's one that's based upon previous writing about militarization and securitization of epidemics and epidemic response. But I'm also it's something that I'm working through still, and the book is due soon. So a little bit of background about the outbreak. I'm sure most people remember it, but it was largely confined to 3 countries: Sierra Leone, Liberia, and Guinea, though there were obviously cases in Nigeria, the United States, Spain, and I believe the United Kingdom, if you count the people who had their relapses there. It accounted for 14,000 cases in Sierra Leone and about 4,000 deaths, and I think there were 30,000 in the region. So it's it was an important period for thinking through questions of health, public health, health security, and a range of ideologies undergirding the provision of healthcare in an emergency. The book is about this outbreak, but it kind of does things a bit differently than other accounts. So it's not a journalistic account. It's not a purely ethnographic account either, because it draws on a range of sources and modality, and uses a range of modalities for generating knowledge and insights about the epidemic. One of the things that sets it apart, I hope, is that I'm trying to engage, bridge African studies and Black studies and the methodologies and modes of analysis between those two, critical global health and this sort of anthropological approach to the politics of knowledge. So the previous work that this draws on comes from a chapter that I wrote in the book, The Politics of Fear, Sans Frontières, and the West African Ebola outbreak. My chapter was called Whose Security? And in that piece, I was trying to grapple with a few different things. And I drew on the MSF archives when this was commissioned. And I was, I think, struck by 2 things. I'd already written a bit about the militarization of epidemics, or the militarization of response in short form, but I really wanted to understand why Doctors Without Borders had for the first time relaxed its ideas or its standards about involvement of military in humanitarian response, or at least its relationship. So for people who aren't familiar, in July, I think June or July 2014, Joanne Liu, who was the president of MSF at the time, requested military assistance. But what she really wanted to emphasize was that military logistics and military logistics and assets could be used without the threat of force or without the implication of force. And so I was kind of trying to figure out why did that seem to be the correct response, or the response from this otherwise sort of pacifist anti-military organization. And the second was another development in Sierra Leone, which was that the president of the country, who at the time was Ernest Bai Koroma, it's now Julius Maada Bio, he transferred responsibility for the epidemic response from the Ministry of Health and Sanitation to the Ministry of Defense. So in other words, much of the coordination that was happening was being done by the military. So this literal military piece, but also this, what I would say, militarization in the sense that Lutz and Inlow discuss or describe. And that is to say that military logics, the hierarchy, obedience, threat of violence, like how does that actually map onto, in other words, the martial politics and martial logics undergirding the epidemic response. I was also interested in securitization, which is different. And part of this comes from another concern with the rise of something called health security, which comes out of biosecurity. And the way that I was looking at this was, so I guess I should just say that one of the things that I argue in this piece is that we can talk about militarization and securitization, but we can't pretend that it didn't always already exist in both humanitarian practice, so the logics, and development practice, the ways that the landscape looks militarized or securitized. So from SUVs to barracks and barricades at compounds for NGOs and NGO households, for expatriates, for elites, national elites. So how do we think about the terrain as securitized, but also the mobilization of security forces during the war and in its aftermath to maintain peace? So this might look, during the war, it looked like checkpoints at mile 91 or checkpoints at all of these different spaces. During the epidemic, that looks like checkpoints to do temperature checks at the same locations at which, at the same locations where there had been military checkpoints during the war. So that's sort of how I'm thinking about it. So how do we, is there something in the militarization or securitization critique, or can we say that we've already crossed that, that stream, we've already crossed that river? The other piece that I also argue, but not in this chapter, is that public health, and in particular, US public health, which has had great influence on the public health system in Sierra Leone, not only in Sierra Leone, but in other parts of the world. I guess the way that I'm looking at this is the highly militarized logics of public health more generally. And for those of you living through a lockdown or some version of it, you know that this might look like contact tracing or but I'm thinking about things like disease surveillance, which emerged in the Cold War with the Langmuir, who was I think he was was he the director of the CDC or the director of epidemiology at the CDC? And the work of Lyle Fernley, Frederick Keck, Andy Lakoff all talk about this, the rise of epidemic intelligence and what that looks like. I forgot that I had these pictures here, but this is sort of like, if I had to kind of sort of have an iconic depiction of what epidemic intelligence looks like, that's Alexander Langmuir on the right. Jeff Copeland, EIS officer, he also was a CDC director. and all of these people sort of understood as the disease detectives, these sort of elite medical detectives. But the less sexy part of this is what surveillance looks like, and that's primarily data collection and constant vigilance and active vigilance around disease events. So we're talking about things like actuarial or sentinel versions of public health that are focused on anticipating, that are focused on preparedness and those other kinds of paradigms. So, but what is this, so the thing that I sort of latched on to in 2014 were the kinds of metaphors being deployed to address Ebola. And so this was October 2014, where there were two things going on. One was there was actually an ISIS threat that was being addressed by the US government alongside the United Kingdom, who also sent 1,000 troops to Sierra Leone. I forgot to mention that for Ebola. But so there was actually this interesting story about ISIS using Ebola as a bioweapon. So an actual literal relationship between Ebola and ISIS. And that was, if you watch Jack Ryan on Amazon, I do not recommend that you do, but I did for the purposes of this research. That was also one of the sort of plot points or threads throughout the series of the first season of the series. And then there was this something else, this sort of analogic, or I don't even know if I want to call it exorbitant analogism, but I'm doing that in another chapter, so I'll call it that. That linked ISIS and Ebola in other ways, right? Which is to talk about the failed governance as the thing linking those two things together. So the fact that epidemic levels of transmission is happening looked a lot like what was happening with ISIS because they are caused by failed governance. So different forms of pathogenesis at the population level being conceived here. Then I'd say, so it's interesting, all of this was happening around the same time when a former chief medical officer and assistant secretary of Department of Homeland Security in the US wrote a piece in the New York Times in which he said, ooh, this did not work. This is no ordinary communicable disease. It is the ISIS of biological agents. The response should mirror anti-terrorism efforts. Now, we could have just left it here. But then this happened within a few days. I think it was October 6th. It might have been the 5th. But all of these things are sort of, these signifiers are clustering together to this sort of system of, I'm trying to think of a way to put it that makes sense. But basically, it had me thinking a lot about what this exorbitant analogism means. Like, what is the literal, will violence associated with this analogy be literalized? And that's long been the concern for me when I talk about the role of the military, but also militarization and securitization of the outbreak. I wanted to kind of go back actually and think about the relationship between the history of public health and this idea of epidemic intelligence and the global war on terror. If in an ideal world, I would try to kind of think through the timeline here. There's some interesting work. I guess it's older now, by Nicholas King, a historian of science, who talks about these paradigms of security thinking that emerged during the Cold War, but that also emerged after 9/11 or around 9/11 with the anthrax attacks and so on. And so I've been trying to also think through the blurring between concerns of national security and this new sort of, I would call it newer concern with global health security, even though health security has a bit of a longer history. So I actually, let me just do an anecdote. And when I was in public health school in the 90s, so we can trace this turning point to 1989, 1990, when the CDC and the US Public Health Service began to worry about emerging infectious diseases as in terms of the kinds of biological weapons and bioterror that could be inspired through the sort of more readily available technologies to both infect and spread certain kinds of diseases. And so when I was in public health school in the late 90s, one of the key issues that we talked about when we talked about disease surveillance, in fact, one of my professors was the head of the Epidemic Intelligence Service. And he would tell us about, basically, he was always talking about how public health and biological science were thinking about the potentialities or the potential of unleashing biological weapons and the use of those weapons by terrorist groups. And when I was looking for a job in 2001 with a public health degree, the interesting thing was a lot of my friends were actually being pulled into these newly created bioterror jobs, going to Colorado, to Fort Collins or whatever to take on these jobs. And that was sort of like a new source of revenue. Some people saw that as sort of a cynical ploy, associating health with security, or public health with national security, a cynical ploy to develop a bigger pot of money for public health. And my argument that I hope to make is that security paradigms for health, no matter how they're spun, get reinvigorated or pulled back into these national security debates that basically help kind of force our focus to things like containment and isolation, and away from paradigms of care, which are really important, not only for actually helping save lives and save people, but also in ensuring an ongoing commitment by governments to provide for people, public health-wise, medical care-wise, and so on. So that as I'm talking about the always already securitized dimensions of health and of public health as a discipline, I'm in dialogue with not just the sort of anthropologists dealing with how security is realized or the ideological underpinnings and its manifestations in everyday practice, but also theoretical contributions that look at biopolitics through lenses of racialized populations, racialized notions of the human. So in addition to Foucault and Agamben, I'm talking Wahelier, Winter, and Spillers. So, and for me, by locating this in Sierra Leone and not the United States, it allows me, or at least forces me to think about Sierra Leone's history in this global and transatlantic practice of security, which is to say, thinking about this history of the protectorate and the colony of Freetown, and thinking about slave trade and abolition, the colonial era and colonial politics of racial segregation for the sake of health security in the city through wartime. So the ways that those actually, and the ways that those boundaries, those choke points, those checkpoints are reanimated in the course of a civil war and in an epidemic. So a little bit of a lighthearted read in the same week, I kind of, I was like, what is this analogy? Ebola, the ISIS of biological agents. Of course, we have this sort of literal comparison, but we also have this metaphorical or analogic comparison that allowed for people to say, if we think of these as having the same root, or if we think of these as having similar processes of evolution, then we understand our solution. We have a really great solution for ISIS. I don't know if that's true, but we also have a really great solution for Ebola. And so Teju Cole kind of made fun of this ISIS as a biological agent. He said, is Ebola the Boko Haram of AIDS? Is Ebola the Al-Shabaab of dengue fever? Some say Ebola is the Milosevic of West Nile virus, and so on. So one of the things I didn't say, but I probably should have, is as an anthropologist who is very much dedicated to fieldwork, I found myself not having the space, time, or clearance to be able to do these field-based assessments in the middle of an epidemic. And so I've had to obliquely get at some of these questions. And one of the oblique ways that I got there was I was just sort of following trails. And this trail was one that was super interesting to me. It popped up in a Facebook feed by a friend who actually studies jihadism. And he said, maybe we should go to this together. It was a joke. I have been to the Imperial War Museum, and I talked to the curator, Matt Brosnan, about this exhibit. And again, it's in the Imperial War Museum in London. And I think it ran from, I think, was it 2017, I think is when it was up. But it's interesting how many Ebola exhibits actually emerged from Ebola. It was like a rapid response collecting. I also write about this in the book, one that was done by the CDC and started collections in 2014. But this one struck me as slightly different, largely because it's in the Imperial War Museum, but also because putting these things together was odd to me. So I called Matt Brosnan and said, well, what's going on here? Why would you do this? And he said it was actually a coincidence. So he has like a package of funding, or had, to address contemporary interventions. And so the coincidence here was that as troops were pulling out of Afghanistan, British troops were pulling out of Afghanistan, they were going to Sierra Leone. And as I said, there were 1,000 troops from the UK, or 1,000 troops from the UK. And what I find striking about this, and I would love to talk to anyone who's interested in visual and material culture, but this division here. And when I talked to him, he said that was the way that they chose to distinguish between these two extremes. So the question that I had for him, though, was what kinds of extremes, beyond the sort of obvious use of extremism to refer to ISIS, what kinds of extremes does he imagine as being represented in this place? So he had this money, and these were the fortuitous things. What extremes does he imagine? Is it and here are some of them, actually. I again want to talk to people about this because I every time I look at this picture, and I haven't done so for a long time, I'm struck by how man and power is divided. So one of the ways that they tried to distinguish between the two extremes was to use colors on the opposite of this sort of color palette, but also to actually draw a big line between the two in terms of how they represent each side. So this blue-green is the Ebola response. This orange, Operation Shader, is the ISIS side. But as you can see, there are these things that are reflected on both sides. So for example, intelligence, health intelligence, or others. Extremism is actually only on one side, but I kind of kept going back to this. Is it compassion? Is it predation? What are the extremes that are supposed to be addressed here? And what drives the necessity or the need to distinguish them diagonally, to distinguish them in this, to draw the line, so to speak. And this is what it would look like when it's actually in space. This is actually one of their smaller spaces. I could tell a story about going to this. I didn't actually go to this exhibit. I went after this exhibit went down, but I still saw these rooms and their divisions, and it's actually quite fascinating. Again, I have a lot to say, but I wanted to actually make sure that I don't overstay my welcome, because I do want to actually have a conversation, or at least an engagement with people's questions. The thing that I've been trying to address more broadly is, it's easy to look at museum representations. It's easy to look at the testimony provided by members of parliament or to members of parliament. It's easy to theoretically imagine the stakes of militarization, the stakes of securitization. But it's not always easy to think about what the implications are for health, for public health. So, I've been thinking about this a lot, obviously, because my critiques are, yes, this coercion, containment, and isolation are not good things to couple with your care. or they don't take the place of care. One of the things that we know from the Ebola epidemic, having reached this grand scale, was that it wasn't enough to trace contacts, and it wasn't enough to interrogate people about their contacts and try to trace them down and pin them down or isolate them. We had to offer care. And we had to offer care that was high quality, that helped to ensure that reassure people that it was good to go to a health center early, that you would come out of it alive more often than not. And early on in the epidemic, people were being told that there's no cure, which didn't mean that there was no treatment. And so one of the things that I've been and one of the things that a lot of my colleagues who are clinicians who work in Sierra Leone and clinicians who went to Sierra Leone to offer care said was, it was really clear that people were looking at just sort of containing folks to contain the epidemic. And it was a novel idea to promote care. And I remember distinctly actually saying this on the radio in Sweden and having people kind of freak out, like, where did you hear this? Like, where is this really smart idea about getting people to the facility early? Why haven't we heard about this? I know it sounds ridiculous in retrospect, but one of the things that security paradigms, particularly if you do a close reading of the global health security agenda to which the Sierra Leonean government has signed on and with which they've helped to redesign disease surveillance systems and everything that goes with it. I think it's $110 million in recent years. Where is the care? Containment is mostly the containment and data collection form the basis or the focus of all of this. And where medical countermeasures are the only, whereas I guess I should say, medical countermeasures as a part of this is the only sense that you get that care is a possibility, clinical care. So I want to close by sort of raising some of the questions raised by colleagues who are working in Kono district in Sierra Leone and who've asked the really, I think, wonderful question: who are Sierra Leone's health security efforts for? And this is on the basis of talking to the nurses and doctors and data aides who are working in these facilities. The focus has largely been on data collection and management. It's been emphasizing disease surveillance. And this has often meant not better patient outcomes for these kinds of conditions, but rather better data. And so the way this looks on the ground is maybe you have an iPad to collect disease data, but you don't have gloves, you don't have electricity, you don't have running water or clean water all the time. And so what does this actually look like? What does this look like in practice? What does a verticalization, which is the topic of my first book, what is this verticalization in the form of disease information and information management technology, management information systems? What does it do for the administration of care in places that are actually supposed to be providing care? So I think I want to stop there because I, again, want to have this conversation, but I just wanted to kind of raise like some of the key points that emerged from or are emerging from the research that I'm doing.
Fantastic. Thank you so much, Adia. I think we have already several questions lined up, but thank you for a terrific talk. Let me just go to the first one from one of our visiting scholars, Jill Hazelton, and we'll follow that with a question from Gabrielle Hecht. And I'm going to build actually on the first one from Jill Hazelton. She asks, as someone who studies terrorism, counterterrorism, insurgency, state building, and similar efforts, is how this project echoes both finds echoes of works on modernization, on the Cold War, global war on terrorism, echoes of Western insistence that good governance is a necessity to end terrorism, insurgency. And I'd also add, just from my own listening of your talk, when you were talking about looking for positions in public health at the end of the 90s, and how so many people were being drawn into these kind of, I'd say, sort of post-Cold War ideas of dealing with ungoverned spaces, or places that somehow needed to be developed. There's a whole cluster of ideas around what countries or what responses should look like that seem to be captured by some of the ideas you're talking about verticalization and securitization of response. I just want to connect that to one other idea, which is, I think, also what you were seeing in the public health sector at the end of the 90s, which is the extent to which securitization reflects just the dominance of military budgets, military spending, military capabilities, sort of overwhelming some of the other kinds of responses that you might have in these cases, such as providing care, which you pointed to. So maybe just probe a little bit more where this sits within sort of a broader problem set of how the world has responded to some of these issues, sort of that as it engages in sort of the broader, to use the term, global South, in sort of this post-Cold War environment, that's sort of this liberal agenda out there, and the way it looks at these issues, or problematizes them. So that was very long. Pick out whatever you like from that.
Well, I mean, I've been thinking about this a lot, right? So because I first moved to Sierra Leone in 2003 to work on a project. So it was sort of so there are a couple of things going on at the time. The first was that we were hosting Liberian refugees from their war. And my work was on gender-based violence. But ultimately, I also got pulled into a bunch of health projects. As we were thinking about post-conflict development, whatever that is. And so it meant, what was interesting is how NGOs in Sierra Leone, at least, were carving up the country into like zones for themselves. So like, okay, so if we, so I mean, I'm trying to think of this in terms of like what a humanitarian regime does. So there's the security umbrella that we all know about, which is you sort of create a space where security, you don't have, your visible presence isn't on the ground, it's from above, which is like an interesting way of thinking about security. But we started to carve up each NGO. If they worked in health, they would be like, oh, well, I will now have, IRC will now own Kinema, Kailan, and so, and we will do their health. And education will be CRS, that is basically like the camp, but scaled up to the district. So, I mean, a lot of what I see in terms of the organization of services it mapped onto humanitarian response, which was in essence also a kind of, was a security response, which was also, so it's when I keep talking about the analogism, there's a literalization of those relationships in the planning and the rollout. Yes, the military is actually I would say, overdeveloped. So one of the things that we did in the post-conflict moment was to say, we need to professionalize the military, which was happening anyway, and professionalize the police, which happened, I think, to a lesser extent. And what that looked like, even during the war period, a lot of my friends in the Sierra Leonean military, because I worked at a Sierra Leonean military hospital for part of my first book's research, they talked about, training in Texas or training in, to do some of their work. And that's actually why the military hospital system was quite good. But I also want to say that because the war is actually part of the war is linked to, or the second coup, I think, that happened, or the first coup that happened in the early 90s in Sierra Leone was launched because the military were not being paid. And so, this is a very roundabout way of saying that when I was talking about Ebola with friends, who were still trying to help sort out health issues with the Ministry of Health and the Ministry of Defense, they said, they were talking about how the military is now in charge of the COVID response. And I said, well, can I ask you a question? When was the last time the military was not paid? And they were like, 1992. And I said, when was the last time health workers were not paid? And they were like, last year. And I said, well, as long as we have that kind of relationship where the military is basically its own sort of mini state with its own socialized healthcare, always on time salary, all great schools, all of that stuff, we're not going to see a demilitarized health. And when I talk to these health workers who are learning about the health security model, so proud of it, they're like, yeah, we're doing our data stuff. We learned how to do, we know how to do this rapid response preparedness thing. And I said, but what about care? How you doing with the clinical care part? And they're like, we want to do the badass disease detective stuff. And it was a very interesting, interesting interplay, seeing how that plays out in the everyday when we're talking about something as basic as healthcare and basic public health that, yes, requires data collection, but isn't the bulk of what needs to be done.
No, I think that's fascinating, both in, of course, what you're pointing to in the way NGOs approach this, which in and of itself sounds fairly militarized, dividing things up into zones that they're going to coordinate, and there's boundaries obviously between those zones, but also just, of course, the role of intelligence and the role of containment, which are both very militarized terms in and of themselves, as you point out. So I'm just watching this from different vantage points and responding to having been also familiar, like Jill, with the literature on sort of counterterrorism, which also is about intelligence and containment, all of this, as you point out from your very title of this talk. Let me go to a question from Gabrielle Hecht, which is, she says, such a fascinating project and framing, thank you. The images and discourse you presented suggest that there's a racialized dimension to the contrast between the containment paradigm and the care paradigm. Can you please speak to that?
Yes, I think there are a few ways that goes. So and what I mean by that is there's a racialization that prefigures what is possible, but then there's a racialization that emerges from the practice of these things. So, or the things that I mentioned, so containment, isolation, and so on. So the prefiguring racialization is that national security element, which ultimately, and I have done this, I was gonna say, if you look at every press conference that Obama did and every press conference that Obama's sort of top health officials did in August, September, October, leading into the deployment of 3,000 troops in Liberia. And if you, every single press conference began with, we want to stop it there to keep it from getting here. And I'm not summarizing, those are actual words. We gotta, and that was always, that sort of, that what I see is the importance or significance of biopolitics is that I think it's a racial theory. It's a theory of racist state racism. And it's also, I think we saw it play out with COVID when Trump kept going, well, let's carve out New York. Okay, New York and New Jersey. Okay, New York and Connecticut. Oh, damn, California. Sort of like, oh, only South Dakota is good, which was, I think, indexing whiteness and rural whiteness as places of safety and security that needed to be protected at all costs. I don't even want to know what was going on in DC. Like, how do you even do any of that racial sorting? And so, and in those pictures, yes, it was superheroes of a certain stripe coming to the rescue. One of the things that I've been thinking about a lot, and I'm writing about another chapter, is the racial history of Atlanta and CDC's role in that, in a bunch of different ways. And so I think to some extent, the racial politics of the CDC and in terms of its organization, but also its placement in the South, but also its location in Atlanta, but also its involvement in certain kinds of racializing practices through the practice of public health, has to be addressed. And that's sort of one of the, what I think is a key contribution of the book, but also of the chapters that address that. But then I also think that there's a racializing element that doesn't really, I guess, map on to, say, US racial regimes, which is that people, I'm thinking about the Ebola survivor as a particular type of person that emerges out of this outbreak, as people who are constantly seen as ambassadors, as immune people who can enter into certain kinds of relationships, as people who serve as a resource in a bunch of ways. So as human resources, as resources from which they can extract, which is actually the current CDC relationship. So in addition to training people to be epidemic intelligence officers, or the kind of like light global South version of that, they're not as elite as the ones in Atlanta. They're not PhDs, MDs, they're people with some degree who can read and write, things like that, which is another kind of hierarchy that I think is brought about through this particular practice. But I'm also talking, there's a kind of racialization emerging from survivorship. So what lives in your blood, whether you can be extracted from. I always tell people about one of the survivors that I met, who's the head of like one of the local survivors associations. And he talks about how he actually ran and was captured. He ran when he was put in an isolation unit, and then fled, and then was tracked by the police and brought back to his original place. And he sort of like a model survivor now, in the sense that he runs this association. And one of his key tasks through the Prevail, I think it's called the Prevail Project at the CDC, which is looking at survivor semen, not survivor breast milk for some reason, but survivor semen. And this guy got on a motorbike and traveled through all of Sierra Leone to gather semen from Ebola survivors. He was not, and the big joke amongst his colleagues, they're like, he's going around doing this like really weird thing. And he knows it's weird because he wouldn't even do it for himself. He eventually did, I guess. But, just having this conversation with a guy who's like, I was like, how does that work? You get on a motorcycle and you say, and you ask for what in a cup? Like, and it was funny, he was doing, and we were just having this conversation. It was so embarrassing for both of us. But it was also this, I'm trying to think of how to put this that isn't sort of flippant, but also kind of grossed out about how people are exploited, and the use to which their identity as survivors makes them subject to certain regimes of experimentation and extraction, and not refusal in ways that you would think. How people get enrolled and enlisted into these categories by participation. So again, to kind of summarize, racialization happens in two different directions. One that maps onto, I think, US and global racial hierarchies, but others that are produced through knowledge, I guess, everyday acts of knowledge production, scientific knowledge production about survivorship.
Great. There's actually a follow-up from Gabrielle on the role of gender as well. And I actually had you just prompted another question that I thought of, this role of cooptation, which I think is a broad, you mentioned this example of survivors being co-opted, but I also wonder, are you seeing out there a discussion among NGO groups or local NGOs or international NGOs of the extent to which they've been, is there resistance to this notion that they've been co-opted into the securitized response to epidemics? I mean, because you mentioned Doctors Without Borders having traditionally a stance of not, right? But it seems like even they, had to concede some measure of cooperation. Is there some sort of counter movement, counter discussion, resistance to cooptation? that you're seeing to this kind of model that you're looking at? So two different questions. One, maybe start with Gabrielle as a follow-up on gender, but just more broadly, a link back to this whole question of, how do people see the alternatives out there?
Right. The gender piece is one that comes up a lot because I also happen to have been, I was like working on two other things when all of this happened. And so one of the things I'd been writing about was disease eradication politics, which have a what I would call hyper-gendered dimension. And I think it is applicable here. Really applicable here as in terms of gender roles particularly I think in the history of epidemic intelligence. And I've made the joke, and one of the reasons I refer to Lutz and Enlow when I talk about militarization and securitization stuff is how those relationships of obedience and hierarchy and violence are gendered. But in those images, and I think to some extent in these images, and I think to some extent in the actualization of or the everyday practices of this epidemic intelligence is, in some ways, it's like a way to butch up public health. So public health has this, and it's not, I don't think that's like the motivation, but I always feel like the reason we keep collapsing into security paradigms is because public health is highly feminized. It's in the sense that it's a care logic, but also it's low for many. It's a low pay, low reward kind of labor, and US public health and US global health in particular, I think, is actually highly feminized as well. It's sort of like the social work. If you were to talk about, US reform as social work in the 1880s or 1920s, it looks like what global health looks like today, which is like, how can we go and teach people how to deal with their babies or whatever? I feel like I'm being a little bit caricaturing in this, but there is that sort of Indiana Jones adventure stuff in those pictures that I showed, right? With Jeff Copeland in the boat, going to do some smallpox eradication, with the guy with his lab coat and his, and that iconography, that expression of masculinity is very much kind of, I think, a part of this disease detective, epidemic intelligence, security framework. I don't know if that's a gendered stereotype thing or what, but I always feel like that recoiling at caring for populations doesn't look like biopolitics that I recognize. It has this gender dimension, this masculinist orientation. I'm reminded too of Andrew Cuomo saying that he was going to kick the virus's ass during the early months of COVID, and I keep thinking about that as like the epitome of that way of thinking, that framework, as well as sending troops in to fight a virus in so many cases and instances. The resistance to NGOs, or by NGOs, to these security paradigms, I think there's a yes and a no. Like, one of the things that I remember and wrote about in the MSF piece was how, so there's a way in which security, at least the sort of sense of security that these kinds of institutions provide in terms epistemological ones or embodied ideas of security, was what helped keep the NGOs working. One thing I wanted to say is people were evacuating. They were like, I don't want to deal with this. I don't want to deal with people. And part of it, the justification was, I think this will make it insecure. This will cause insecurity. Where it's not like a symptom of it, it's actually a producer of. And so what folks were kind of trying to deal with is, how do we ensure that people feel safe and willing to do their job? But then there's this other piece that, yes, people were actively also resisting. So some NGO folks in the stuff that I read in the archives, they were very much like, no, we don't feel comfortable, because we don't want people to think that we're associated or affiliated with this institution that also causes harm. That said, the efficiency and capacity of the military to do lots of things is also what makes it so attractive, even if it's not real. Like, even if it didn't produce that efficiency that we heard was going to happen, there's the possibility, you know, and in fact, there were military folks who said, we felt like it didn't even matter what we did as long as we were there. I do think that so I guess what I would say is I think there is some pushback. I think it depends on the context, and I think it also depends upon, I think it always depends upon whose security is at stake, what is being secured, from what, by whom, and that operates, that's a question or a set of determinations or deliberations that happens in an inequitable, unequal sort of field, right? It's and that's ultimately what I think is the problem, or the thing that makes it such a thorny, kind of difficult thing to balance and address.
Sorry, I muted myself. In fact, a couple of our commenters actually in the chat, which I missed until just now, commented on some of these issues. Marianne Ferm comments that, in fact, the logistics in the military, their larger budgets, and how that's often used as a justification for calling on them, and points to the example of the country's newest hospital at Jui, J-U-I, in Sierra Leone. And how Chinese military contingent helped them set up their isolation unit very quickly. And so this is, you know, she was pointing to agreeing with you, I think, on the fact that sometimes the practicalities just lead people to reach for the military. So let me, there's another question in the chat from Lauren Ho, who asks about the relationships between humanitarian aid, security responses, and bureaucratic organizations in both the US and international government responses to COVID-19, and to the extent which some of your research is applicable to that, or you mentioned wanting to look at the CDC in Atlanta and sort of its responses, and sort of made some of the connections between what you were seeing in response to Ebola in West Africa and what you're seeing in response to COVID today.
Okay.
A little bit more speculative, maybe, but.
So, yes, there are literal relationships between humanitarian aid, security responses, bureaucratic organizations. Yes, 100%. I think I did actually answer that happened. Yeah, in the sense that, well, I think I mentioned that at least in the Sierra Leonean case, they didn't even do the Ministry of Health. They didn't even bother with the Ministry of Health this time. It's just Ministry of Defense does it. There's not even like a question. I was like, what's going on? The press release on March, whatever, 2020 was, the person in charge is former Brigadier General, blah, blah, blah. You know, it was not even a question. Maybe it was a question, but it was not a question that I was privy to. And that's just, I think, just the way it is. I think it's just sort of the practicality issue. So what happened in the past 5 or 6 years since the Ebola outbreak happened, right? Like, why isn't it that, you know, that other institutions are able to mount an emergency response? They also declared a national emergency in March 2020. I believe that, and so yes, the other lessons would be that the emergency happened fairly quickly in places like Sierra Leone. They absolutely said, okay, we're going to need 200,000 masks. Oh yes, we're going to pull our leftover PPE. There's also an Ebola outbreak in Guinea right now. And so Sierra Leone is going, okay, so what do we have to do to prepare for this? What are we going to do? So that is the thing that's happening. Like, people are much more readily mobilized, but this pathogen matters, right? Ebola is easier, in my opinion. It's deadlier, but it's easier, which is probably why it's easier. It's people don't spread it unless they're symptomatic. That's not true with COVID. You can be in the same space with an Ebola positive person, as long as you're not coming into contact with their fluids. And that is possible. That is not possible with COVID-19. So having different kinds of restrictions, like reducing public transportation, reducing, they have this ridiculous curfew in Sierra Leone now that's like 10 p.m. to 5 a.m. or something, and no restaurants or bars on the weekend. Like, if you ever spend any time in Sierra Leone, you're like, but that's when the magic happens. Like, you have to be at the bar from like Friday to Sunday or whatever. That's just the way it is. People like fun. Yes, they're mobilizing things in ways that resemble Ebola response. They're rapidly mobilizing in ways that resemble, because of that experience. On the other hand, what will care look like? I think there was 79 deaths, according to 79 deaths from COVID in Sierra Leone. 3,000 cases. Largely a lot of, so I mean, there's a longer story there, but it's like a thing to think about, which is the extent to which Ebola preparedness prepared places like Sierra Leone for this outbreak. So. Oh, interesting. Sorry. Yeah, like I saw what Marianne wrote. The Liberian case is very different from the Sierra Leonean case. Yeah. But I should say, because I do know something about the Guinea case, or the Liberian and the Guinea case, is I don't think Liberia ever fully militarized. I think the way they did it was they sent the military to kill people. I mean, to keep people in West Point, but in Monrovia, and the US sent 3,000 troops, but ostensibly it was to build infrastructure and never deliver care. Which I think raises some different kind of organization of at least governing health emergency.
Thank you. I think we're almost at our end of time, but I think for some reason the title popped into my head as I was listening to you talk, of a book by Rosa Brooks, where I think the title sort of says pretty much everything. I think it's something like how war became everything in the.
Yes.
Yes.
I know that book.
Yeah. But it seems appropriate here for the response to Ebola and across a number of other range of issues around the world. So I think there's the really interesting analogies between what you're working on, and I mean, some of my own work on it. Personally, I'm very interested because of my own work on sort of alternatively governed spaces and other approaches to dealing with responses that differ so much from what we've seen from these more securitized responses, not just to this, but to a whole set of other issues. Well, thank you everybody for joining us for our weekly research seminar. Thank you to Professor Adia Benton for discussing the research for her latest book. A really fascinating, and we really appreciate you joining us this week.
Thank you so much. It was great. I was forced to boil the essence. So
it's fast. An hour is not really much time to talk about an issue with this much depth, but we're really, really appreciative.
Thank you so
much. Well, thank you all.